be talking about procedural sedation here at VRH, what the policy is, a little bit of the medications behind it, and what the responsibilities are of the various members of the team that are going to be participating in this. We're going to start off with the basics of what is procedural sedation. So procedural sedation is a technique of administering sedatives or dissociative agents with or without analgesics to induce a state that allows the patient to tolerate unpleasant procedures while maintaining cardiorespiratory function. Procedural sedation is intended to result in a depressed level of consciousness that allows the patient to maintain oxygenation and airway control independently. It can range on a scale from minimal to deep sedation, but does not include general anesthesia. There's a couple of different levels I want to talk to you guys about, and we're going to start with minimal sedation. So that is a drug-induced state during which patients respond normally to verbal commands. Although their cognitive function and coordination might be slightly impaired, respiratory and cardiovascular functions are unaffected. In moderate sedation, it's a drug-induced depression of consciousness during which patients respond purposefully to verbal commands, either alone or accompanied by light tactile stimulation. A patent airway and spontaneous ventilation remain adequate without any types of interventions. Deep sedation is a drug-induced depression of consciousness during which patients cannot be easily aroused, but respond purposefully after repeated or painful stimulation. These patients may require assistance in maintaining airway patency and ventilatory effort. And then general anesthesia is a drug-induced loss of consciousness during which patients are not arousable, and they may have an impaired cardiorespiratory function requiring varying degrees of support. The patient under general anesthesia is profoundly compromised and does not exhibit movement or autonomic nervous system responses to a standard surgical stimulus. So what level do we want when we do procedural sedation here at VRH? So the goal is to complete the procedure with the least amount of sedation necessary. If that means you can achieve your goals and keep them at a minimal sedation level, then that's great, and that's what we should be striving for. So for the purposes here, we should not intentionally be going above a moderate sedation level. What kind of patients is procedural sedation for? There's a couple of different patients that this works for and some that it doesn't. So for the inclusion criteria, it's intended for patients of all ages who have conditions that require pain and or anxiety management to successfully accomplish an interventional or a diagnostic procedure. High-risk patients are included with the understanding that these patients are at an increased risk of complications from procedural or moderate sedation and analgesia, and the use of an anesthesia provider should be considered for any of our high-risk patients. And our exclusion criteria includes quite a few more pieces. So it's not intended for patients receiving inhalation anesthetics, patients who receive analgesia for pain control without sedatives, because then that's just treating their pain. Patients who receive sedation solely for the purpose of managing behavioral emergencies, that would be a chemical restraint. Patients who are intubated because their airway is now protected, so we can hit them with a high level of sedation because we now have control of their airway. And patients who receive an anxiolytic or subdissociative doses of sedatives for minor procedures at the discretion of the provider would also not count for procedural sedation. Pre-procedural fasting is just something that we want to touch on. So recent food intake is not an absolute contraindication to the administration of procedural sedation, but the provider or the proceduralist must weigh the risk of pulmonary aspiration and the benefits of providing procedural sedation in accordance with the needs of each individual. So their last oral intake should be documented for all procedural sedations and may be used when considering timing and target level of sedation when faced with a patient who had recent food intake. Because what we don't want to do is give somebody a lot of sedation and they just had, say, maybe 2 Big Macs and a large fry from McDonald's. And now once we get them sedated, we have them lying flat for this procedure, they vomit, they aspirate, they may end up needing to be intubated for the aspiration, develop aspiration pneumonia, and the list kind of goes on and on. So we really just want to make sure that what we're doing is in the best benefit of the patient. And if that means that they need to wait several hours until they can have their procedure done, then that is a potential. There's a couple different type of personnel that are required to do a procedural sedation safely and that are required for doing it here at VRH. So the minimum number of personnel required is 3. You have the provider or the proceduralist, so they're the same person, the patient monitor, and the airway monitor. For any patient under the age of 12, the airway monitor must be a respiratory therapist. It's encouraged, not required, but strongly encouraged that respiratory therapy be present at as the airway monitor at all procedural sedations, regardless of the age, but it must be them if under the age of 12. The patient monitor is the nurse or the paramedic that is going to be assisting with medications and monitoring of the patient. They must be free of all of their responsibilities throughout the sedation and the procedure. The provider or the proceduralist, whatever you want to call them, the term's interchangeable for the purposes of this policy and presentation, must have privileges for procedural sedation as per separate hospital credentialing requirements. So if a provider is asking you to push a medication as a procedural sedation, but say they're from the inpatient unit, if they're not credentialed to do so, then that would be something that they would be aware of, but then they wouldn't be able to give that order. Nurses and paramedics functioning in the patient monitor role must have received special training and passed the VRH procedural sedation competency test, which is on Elsevier. They have to be ACLS certified, and if monitoring a pediatric patient, be PALS certified. And again, at this time, only the ED and same-day nursing staff are approved for procedural sedation here. So if you're not from one of those two departments, or if you're not from the resource pool who is also signed off to do procedural sedation as they float to those areas, you cannot do procedural sedation here. All those involved with the procedural sedation must be prepared and able to rescue a patient from the next deeper level of sedation from that in which the patient's currently in. So if the patient progresses to a deeper level of sedation than intended, so say we started at minimal, we kind of fell into the moderate category, they still weren't being adequately maintained, gave a little extra of medication, and we entered the deep sedation, then we've now passed our goal, and we want to stop the procedure until the patient returns to the intended level of sedation and make sure that we appropriately monitor and assess that airway and that their ventilatory status is intact. So I just want to go through the responsibility of each individual staff member that's going to be involved. So the provider and the proceduralist. So the pre-procedure patient assessment should include, but is not limited to, a review of their medical history, allergies, current meds, last PO intake, current vitals, current weight, pregnancy status, a physical airway evaluation, a physical pulmonary and cardiac exam, and a general neuro status. Providers also need to ensure they obtain consent from the patient or the guardian POA of the planned procedure and planned sedation, including risks, benefits, alternatives, and signed consent forms. The pre-procedure timeout needs to be performed and documented. Appropriate documentation of planned procedure, sedation, and any other complications must be noted in the chart. And once the sedation medication has been administered, the provider shall be readily available in the department and not undertake any non-emergent duties that would prohibit an immediate return to the patient's bedside until the patient reaches pre-procedure state. All right, our patient monitor, who could be an RN or a paramedic in the ED or in the same day area. So until the procedure and necessary documentation is completed, the patient monitor will not have any other responsibilities. That one patient will be their primary responsibility. The pre-procedure assessment should be done in conjunction with the provider, as previously outlined in the last slide. They want to confirm the readiness of necessary equipment as indicated, including the code cart, oxygen suction, medications, et cetera. And we're going to talk about that in a couple of slides. They're going to participate with the provider in the pre-procedure timeout and document that. A sedation score needs to be obtained before sedation, after sedation, at the time of discharge to ensure that the patient is appropriate to be sending home. Administration and documentation of medications ordered, administered, and the patient's response to those medications. Ongoing monitoring and recording of vital signs, SpO2, end tidal, cardiac rhythm, level of consciousness must be done at appropriate intervals throughout the procedure, minimally every 5 minutes, pending the patient's status. There must be documentation of significant changes and response to those changes. Post-procedure monitoring until patient reaches their pre-procedure state, which means typically doing an assessment every 5 to 10 minutes for the first 15 to 30 minutes and less frequently as they reach their pre-procedure state, keeping in mind that the nurse is still in the room with that patient one-on-one during this time. And once sedation medications have been administered, that patient monitor shall remain in the patient's room until the patient has returned to pre-sedation baseline. And once all of the documentation is completed, you want to ensure a copy of the sedation record is sent to anesthesia for review. The airway monitor could be a nurse, paramedic, or ideally a respiratory therapist. And until the procedure is completed, the airway monitor will have no other responsibilities, which can make it challenging if it's a respiratory therapist, as I know certain parts of the day, there's only one respiratory therapist available. They'll be responsible for ensuring a patent airway is maintained along with positive end-tidal CO2 throughout the procedure. They'll take appropriate steps within their scope of practice and training to maintain a patent airway. So that could be putting in a nasal trumpet. It could be putting in an OPA and doing bag mask ventilation if the patient were to have severe respiratory compromise, while making sure that the provider is aware that you've escalated now past moderate sedation into a deeper level of sedation. In the event that the airway monitor is unable to maintain a patent airway, the provider will be notified immediately and intervene as necessary. So if they're in the middle of the procedure, you'd have to let them know, I need you to stop because I now have an airway complication. And the airway monitor will remain with the patient after the completion of the procedural sedation until such a time that it's determined the patient is capable of maintaining a patent airway without intervention, they're responding to verbal commands, and the patient monitor, so the nurse or the paramedic that's doing the patient monitoring, is comfortable assuming all patient care. So that means that they don't feel that they need that second person there because they've recovered to a state where they can be maintained. All right, what equipment do you need to do a procedural sedation? So the following equipment should be in the room before you get started. An appropriately sized BVM with an appropriately sized mask, appropriately sized oral or nasal airway, intubation equipment of various sizes, a source of suction, whether that be portable or wall mounted, but usually we have access to portable in all the rooms, so that is ideal. But you want to make sure it's fully set up. It's got a yank hour, it's got the tubing, it's ready to go. Specific pharmacologic reversal agents that might be appropriate to the medications that you're being administered. A pulse ox with an audible beep and alarm. So the idea behind the audible beep is that it can very quickly tune you into if there's a change. So turn the audible beep on. End-tidal CO2 nasal cannula for continuous waveform capnography monitoring. A blood pressure cuff that should be cycling at least every 5 to 15 minutes. It kind of depends on where you are during your procedure. Cardiac monitor that's on, doing continuous cardiac monitoring, a functional IV. A nasal cannula, just have them on a nasal cannula anywhere from 2 to 4 liters so that they can get some passive oxygenation with that. And if you notice, most of these items are in each room and in the code cart. So one of the easiest ways to make sure you have everything that you need is to have either the adult or the pediatric code cart in the room with you when you're doing the procedural sedation, and then run through your list and make sure that you have everything additional that you may need. And then that way everything's right at your fingertips if you were to need it. So let's just talk about the medications and some of the reversals. So agents that are considered anesthetics at higher doses might be utilized in a manner intended to achieve procedural sedation. So there's several different medications that we could see. Etomidate is a sedative hypnotic agent that can induce sedation within 30 seconds after administration and can last between 5 to 15 minutes. It has no analgesic effects, so it does not do anything for pain. A normal dose is 0.1 to 0.15 mg per kg IV push if used for procedural sedation. Nursing consideration wise, be aware that it can cause trismus, which is that tightened jaw that doesn't easily allow for the mouth to open. We don't recognize it because we usually only use etomidate for inductions, and it's followed pretty quickly with a paralytic. And so that tightening isn't ever really noticed. But if you're doing it for the purposes of procedural sedation, that can happen. And it can make the airway plan a little bit more challenging and more complicated. And so if that were to occur and you were to have any difficulty with ventilation, you need to let the provider know immediately, and they could potentially need to move to an intubation if they can't get relaxation of that jaw to be able to maintain a patent airway. You could also consider doing a nasal trumpet in that situation and see if you can get a decent flow of air through a BVM that way. Midazolam is a benzodiazepine. It can take 30 seconds to take effect after administration and lasts anywhere from 15 to 30 minutes. Again, it has no analgesic effects, so that pain is not going to be controlled. Normal dose is anywhere from 2 to 5 milligrams IV push. Nursing consideration wise, it can have a long half-life, and so it can prolong the sedation. So it could make that post-sedation assessment take a little bit longer to get back to the normal baseline. Can cause a slow respiratory rate, decreased tidal volume, and respiratory arrest if given in non-intubated patients, which would be this patient population. You want to be really cautious about their airway and their ventilation status, really. So their airway may be patent, but if the respiratory rate drops from 16 to 4, then that needs immediate response. It can cause anterior grade amnesia, and it can cause hypotension. So be cautious. What I used to like to do is just, almost give smaller doses so that you can always give a little bit more, but you can never give less than what you've already given. Fentanyl, it's a narcotic that allows for pain management. It can be given with another sedation medication for the purposes of procedural sedation. It takes effect within 30 to 60 seconds. After administration, lasts about 15 to 60 minutes, depending on the patient. Normal dose is anywhere from 1 to 2 mics per kilo, IV push. Respiratory depression and arrest can occur, though, if given to non-intubated patients with or without additional sedatives. So just be cautious. And somebody, you might look at them and think they could handle 100 mics of fentanyl, and you give that and they can go into a respiratory depression if they're narcotic naive. So again, if you kind of start low, give little aliquots at a time, see how it does with your sedation and with your pain management. It can be a beneficial way of moving through this. Ketamine is dissociative anesthetic. Takes anywhere from 45 to 60 seconds to take effect and can last anywhere from 10 to 60 minutes, depending on the dose and the patient. It does both have sedation and analgesic effects, so it is a really nice one for procedural sedation. Normal dose is 1 milligram per kilogram IV push over 1 minute, and strongly consider a half dose for elderly patients. But this cannot be pushed by the nurse or paramedic for the purposes of procedural sedation per the New Hampshire Board of Nursing. It must be given by a provider. It can be given IV if it's for a induction medication, if we're moving to an intubation and the nurse or paramedic gives it as an induction med for that intubation. It can be given to patients that are already intubated and their airway is maintained, but it cannot be given for the purposes of procedural sedation. Now, that does not mean that you can't give IV ketamine for pain, because if you think about it, a pain dose is 0.1 to 0.2 mg per kg, whereas a procedural sedation dose is about 1 mg per kg and an intubation dose is about 2 mg per kg. So when you have that pain dosing, it's a significantly smaller dose, and that's why it's okay for a nurse to push IV ketamine in a pain dose. Not appropriate for the purposes of procedural sedation, but it could be given if you were using it for procedural sedation IM. It could be given by the nurse or the paramedic IM. It's just specific that ketamine IV not be able to be pushed. And rapid administration can cause respiratory depression and pretty significant laryngospasms. This medication can cause nystagmus, so you'll see those eyes going back and forth in a zoned out look from the patient. Can cause increased secretions, especially at higher doses. So if you have a patient that starts having a lot of oral secretions, it's most likely from the ketamine. So you want to make sure that you keep that airway clear because it can get pretty thick pretty quick. Emergent reactions can occur when the patient is underdosed or overdosed. So ketamine's a hard one where you really have to hit that sweet spot with the dosing. Otherwise, they can have pretty significant reactions and have vivid hallucinations. They can have delirium. They can become extremely violent and agitated. And midazolam is used as the counter agent to an emergent reaction and should be readily available if you're giving ketamine. Propofol, it's a lipid-soluble medication that causes sedation and amnesia. It takes about 15 to 45 seconds to take effect after administration and can last for 5 to 20 minutes, depending on the patient. Has no analgesic effects. Normal dose is anywhere from 10 to 50 milligrams IV push. And this is another one. It cannot be pushed by a nurse or paramedic if given for the purposes of procedural sedation. It can only be pushed IV by a nurse or paramedic if given as an induction agent for an intubation. So this must be given by a provider, and it can cause significant bradycardia and hypotension. So really be cautious of using this for procedural sedation. But again, has to be given by the provider. Ketofol, that's a combination of ketamine and propofol. So the provider would make a 1-to-1 concentration. So an example of how you would do this, if you mix 100 milligrams of 10 ml ketamine and 100 milligrams of 10 ml propofol, then in a 20 ml syringe, every 1 ml would have 10 milligrams of ketofol. It does allow for both sedation and analgesic effects. It is fairly popular in a lot of facilities. It does work fairly well. Normal dose tends to be around 0.5 mg per kg, followed by another dose of 0.5 mg per kg if needed. Again, this should be fairly obvious at this point, since a combination of ketamine and propofol cannot be pushed by the nurse or paramedic, has to be given by the provider. It can cause laryngospasms, apnea, respiratory depression, transient hypotension, and cardiac arrest in patients with significant cardiac disease. and can cause nausea, vomiting, and emergence reactions as it contains ketamine. So any of the side effects that you would see for ketamine and propofol, you can see in ketofol. Narcan, it's an antidote that reverses the effects of narcotics in the setting of an overdose, can be given IV, IM, sub-Q, or intranasal. Normal dose IV is 0.4 to 2 milligrams, and doses might need to be repeated every 2 to 3 minutes. A lower initial dose, like 0.1 to 0.2, should be considered in patients with a chronic history of narcotic use, so that we avoid acute withdrawal. If administering this, say you gave a patient a higher dose of fentanyl and then they had a respiratory compromise while you're assisting with ventilations or their oxygenation, provider says we want to give some Narcan, stand back a little bit after giving it. You don't want the patient to abruptly wake up and almost kind of like panic because they don't know what's going on. They're suddenly being awoken. They may be in a lot of pain, and you don't want to be within arm's reach until you can reorient them. You want to make sure that you're maintaining that airway. So again, even if the patient is being given Narcan because of a potential overdose, it does not mean that you wait to ventilate and oxygenate and you just think, okay, I'll give Narcan and we'll see how they wake up. No, you need to make sure that you're appropriately ventilating and oxygenating them up until the point where they're able to do it independently. And anybody receiving a reversal medication needs to stay for at least an hour to monitor for reemergence of the overdose symptoms. Flumazenil or Ramazicon is another antidote that reverses the effects of benzodiazepines. Normal dose for reversal of procedural sedation tends to be 0.2 milligrams over 15 seconds. An additional 0.2 milligrams given over about a minute is needed up to 4 times. Max cumulative dose is 1 milligram. Again, you want to make sure you're maintaining that airway. So even if the patient's getting flumazenil because of a potential overdose, it doesn't mean that you wait to ventilate or oxygenate. They still need to stay for at least an hour to monitor for emergence of overdose symptoms. And you want to be extremely cautious in administering this if the patients are on chronic benzos at home, because the reversal can cause seizures. Documentation requirements. So there is a procedural sedation record. It is on the pulse under forms. The top piece, which is what's included on this slide here, should be filled out by the nurse and the provider before the procedural sedation takes place. This is that pre-procedure assessment that we talked about earlier, and it should be fully complete. So all of this should be filled in. You should have reviewed as a group that sedation consent is signed. If you consulted anesthesia, airway assessment is done by the provider, H&P, patient identifiers checked, site marked if you're doing a procedure on a site, your timeout time, who's responsible for what, who else is present, and have both the nurse and provider sign before you start the procedural sedation. Then the bottom part of that page includes the vital sign portion. So you can easily document the blood pressure, pulse, SpO2, respiratory rate, and your AV-PU of the patient, and then any other medications and nursing notes that you may give. So you could document roughly here what time something was given, if you gave a fluid bolus, if you applied oxygen, any of those things. And then just as a reminder, AV-PU stands for alert, verbal, painful, and unresponsive. And it's kind of your quick and easy way to assess your patient's sedation level. So if we remember when we're going through the levels of sedation, moderate sedation, which is what we're going for in our procedural sedation, actually we're trying to get the least amount of sedation as needed. But if we were in the moderate sedation, the patient can still respond to verbal stimuli. We should not be in a situation where they're responding only to painful stimuli. That is deep sedation, so we've gone too far. On the back of that record, at the top part of the page, you'll see a more robust sedation score that needs to be completed before the medication's given, so their pre-sedation score, after, and at the time of discharge. And then finally, on the back portion of that record on the bottom, is the discharge criteria. So the nurse or paramedic must confirm that the patient has discharge orders from the provider, they can ambulate without dizziness, they're at their pre-procedural level, they're free of nausea, and they have stable vital signs. They're back at their baseline. And then this entire document must be completed and a copy must be sent to anesthesia. And if the patient's transferred, it's still, you report out where they went and who report was given to, and that nurse still needs to be signing this. And the important piece is to send it to anesthesia. All right, guys, if you have any questions, you want any follow-up on this, anything further training-wise, more than happy to do any of it with you. Please just reach out to me. And thanks for watching it.